Hi everyone, my name is V.
Hi everyone, my name is Catherine, and today we are going to be doing a presentation on end-of-life care for patients with DMD.
What is Duchenne muscular dystrophy? So, as we learned in class, DMD is a genetic disorder that's characterized by progressive muscle degeneration and weakness due to the absence of a protein called dystrophin. And this disease primarily affects boys with symptoms appearing between the ages of 3 and 6, so pretty early on in life. And the average life expectancy, as we learned, is anywhere from 18 to 25 years old. But now, with new medical advancements, patients could reach up to like 30 years old with early treatment. And throughout this course, we've learned a lot about past and current research, which is very important for finding potential cures and treatments for DMD. So we also learned about a holistic approach to treating patients with DMD. So in this presentation, we wanted to focus kind of more on the psychological component and expand on a topic that we didn't get the opportunity to cover in class, which is end of life care for patients with DMD. And this is important to learn about. So it's important to learn about both palliative care and hospice care for patients with DMD, as this is a current reality of the disease progression. So taking some time to learn about this topic is critical to providing the best form of care for patients with DMD.
So you might be wondering, why are we raising awareness on end-of-life care? So firstly, it's destigmatization. So DMD is already a hard disease to face, and with stigmatization towards the end-of-life care, healthcare providers can find it even more difficult to approach because it is so stigmatized within today's society. And this can really prevent patients from getting the care that they require because they could possibly be avoiding it out of fear. Thus, by destigmatizing end-of-life care, we will be able to help aid patients in getting treatment that could help provide them comfort and improve their life quality sooner rather than later. Furthermore, by raising awareness, we are also raising awareness on the support that end-of-life care could bring for loved ones. It could bring emotional and practical support for families, help foster proactive decision making in families, as well as help to give families a sense of comfort, knowing that their loved one would have a better quality of life. Next, we are going to move on to what is palliative care. So, palliative care is a part of end of life care, but it is encouraged to be provided throughout the lifespan of someone that has already been diagnosed with a terminally ill disease. So, as it says on the slide, it is specialized medical care. It helps to improve the quality of life for people living with serious illness. It is appropriate to start at any age and illness stage. It can be provided with curative treatments, and it also transitions to hospice care, which we will cover in the next slide, or an increased emphasis on comfort care depending on the patient upon a 6-month death prognosis by the doctor. So, palliative care entails specialists that communicate directly with doctors to help create a curated plan, extra time for communication about health goals and treatment options, as well as help with navigating the complicated health system. Some benefits are that, once again, you get more control over care. It helps to improve your quality of life, and it provides support for not only the patients, but also for their family and loved ones.
So now we're going to talk a little bit about what hospice care entails. So both palliative care and hospice care are part of end of life care, but hospice care is essentially end of life care without the curative intent. And so some important facts about hospice care that some people may not know are listed here on the slides. So we'll just start with the goals of hospice care. So it's to ensure comfort and quality of life, again, without the curative intent, as mentioned. And hospice care could be given anywhere, really. So in the home where the patient may be most like comfortable around like loved ones, or in assisted living facilities, or even at the hospital. And hospice care is a team effort. So some key players are listed here. So we have physicians, nurses, social workers, caregivers, chaplains, and volunteers. So I'll expand a little bit on the role of social workers and chaplains. So social workers provide counseling services and then also practical assistance. So for instance, planning schedules or transportation or even finances for the patient and their family. And then they also help support the family and advocate for the patient's wishes. And then in terms of chaplains, they play a role while the patient is on hospice care, and also after the patient has passed away. And so chaplains play a role in providing emotional and spiritual support. And then lastly, in hospice care, there's also an opportunity for family support, meaning any bereavement services after the passing of the patient, so the family can receive both emotional and spiritual support. So next up, we'll be talking about how end-of-life care is unique specifically for patients with DMD. We'll be covering kind of four main key points here. So the first one is going to be the young age of the patient, and then the second one is the fact that the patients will typically have complete lack of mobility by the time that they're either receiving palliative or hospice care. And then lastly, or in addition, we have the addition of palliative care before hospice care for patients with DMD. And then lastly, the involvement of many specialists, including or emphasizing the holistic approach to the patient's care plan. So first up, we have the young age of the patient. So typically, patients with DMD will be diagnosed again from a very young age. So here we have kind of the disease progression listed on the slide. So in childhood, we'll typically see a loss of strength, function, and flexibility, mainly in the hips, and then thighs, shoulders, and pelvis. And then progressing into the teen years, we'll see a loss of function that progresses to the arms, trunk, and then lower legs. And then by mid-teens or early teens, so like 12 or 13 years old, we'll see complete loss of ambulation, and then also some cardiac and respiratory complications arising. And um, the life expectancy for patients with DMD is 18 to 25 years old. So again, these patients are who are in like hospice care or receiving end of life care are very young. So that isn't a super common like occurrence depending on like the disease, but typically we see older patients. So this is something that's unique to DMD. So something important that we wanted to highlight was the focus on quality of life when it comes to young patients who are receiving end of life care. So this could mean like encouraging activities such as like hobbies like listening to music, art, and then like video games, things like that, that they could participate in. And then lastly, it's important to provide support for both patients and caregivers to help them cope with a shortened life expectancy. And this includes anticipatory grief. So we could help with anticipatory grief through like counseling and support groups and those types of services. Lastly, I wanted to highlight something called respite care, which is basically a service that provides temporary relief to both primary caregivers and like other caregivers who are responsible for the ongoing care of individuals with like either chronic illnesses or special needs. So basically, the primary goal of respite care is to have either a volunteer or a trained professional come in and spend some time with the patient or take over the caregiving responsibilities. So that way the caregiver could have some of their own time just to tend to like their personal needs and keep up with their mental health, things like that. And then secondly here, we wanted to highlight something that's unique to DMD patients when it comes to end-of-life care is the complete lack of mobility. So it's important that we have certain home modifications for these patients when they're receiving hospice care, such as some home modifications include specialized mattresses and cushions to prevent pressure ulcers due to the lack of movement, and then also the addition of grab bars in the bathroom or like hospital beds in the home or hoists and ramps for easier like mobility and like access around the house. And then something else we wanted to highlight was the intense care, so 24/7 care for these patients, which includes tasks such as like bathing, feeding, and dressing. And then lastly, we have the psychological and emotional component that comes with this lack of mobility. So in a lot of patients with DMD or those who have a complete lack of mobility, there could be a sense of like a feeling of like being dependent or that lack of that lack of autonomy. So it's important that these needs are also taken care of. And these could be taken care of through counseling or musical therapy, and also adaptive technology for communication and interaction. So, like being able to talk to like friends or family via like Zoom or Skype or something like that.
The next part that we're going to be talking about is palliative care prior to hospice care. So, as we have stated before early in the presentation, DMD is a disease that primarily starts when the patient is young. Thus, for palliative care, it usually will start earlier and it would involve more family-centered pediatric palliative care, which we will cover in the next slide. There's a six-pronged approach for DMD patients, which includes first the management of complex symptoms, then crisis support, then intermittent relief for caregivers, then care coordination, advanced care planning, and eventual end of life hospice care. Overall, palliative care for DMD patients is just another layer of support. It's not really to replace the main doctors, but instead to provide support for pain management, respiratory, psychological, nutritional, or comfort care for those who have lost mobility. Next, we're going to be talking about the involvement of various specialties. So, as we have said before, DMD is a disease that starts when the patient is extremely young. Thus, they have a different palliative care team than other patients. So, DMD palliative care team specialists vary. We really want to emphasize this. The DMD palliative care teams vary from child to child, but these are just some of the specialties. So, for those who start palliative care when they're younger, they have a more pediatric centered palliative care specialists. This can include something like a play therapist, which is like counseling for children. Play therapists use play to help children express their feelings through mediums they are used to, such as toys, rather than using words. Next are child life therapists. These therapists help to implement a family-centered care model, which provides emotional and spiritual support and helps children and families navigate through challenging and emotionally draining processes of hospitalization, help them work through feelings of past and impending experiences, and help them to prepare for upcoming procedures. Next is a child behavioral specialist. And this is one of those specialties that's more on the based on the child's need. So it can be really difficult losing function in limbs, and it can be really frustrating for children to see others who are able to just like freely move around. And it can help them, or it may help them to get a child behavioral specialist if they start to feel isolated from their peers. So these specialists help to assess and treat mental and emotional disorders. Next, the child behavioral specialist kind of turns more so into a mental health specialist as the child with DMD grows older. So for DMD patients, once again, it can be really difficult to face constant treatments. Thus, mental health specialists help to provide mental health therapy. Next is a specialist that's more centered once again for DMD patients, which is the transportation specialist. So towards their later years, DMD patients lose function and not only their lower limbs, but also their upper limbs. Thus, a transportation specialist could be needed to help transport these patients to their preferred places of care. Next are dietitians. Once again, for patients with DMD, their medications cause more of a weight gain symptom. Thus, compounded with their inability to exercise, a dietitian could be needed to help create a healthy, balanced diet. Furthermore, later in the stages of DMD, when the patient requires a gut tube to eat, the dietitian it could also be there to help make those adjustments. Next are rehabilitation therapists or physical therapists. These therapists are needed in order to create daily stretching routines to help maintain as much function as they can in the patient's limb. Next are pharmacists who help to prescribe medicines needed for the DMD patients. And then there's management specialists who diagnose and treat chronic pain using advanced therapies, and chaplains and nurse practitioners, which we have explained before.
So now moving forward, we wanted to highlight three key points in order to help with approaching end-of-life care with empathy, and this includes communication, person or patient-centered care, and then the support of patient autonomy. So in terms of communication, it's important to employ active listening and provide a welcoming space for open conversation surrounding DMD, and then validating emotions and concerns. And then in terms of person or patient-centered care, it's important that Caregivers or all those involved in the patient's treatment plan is culturally sensitive. So this means being respectful or understanding of the patient's values, patient or family's values, beliefs, and desired approach to the patient's care. And then lastly, because of factors mentioned earlier, such as like complete lack of mobility, it's important that caregivers are able to support patient autonomy and helping increase that sense of independence. So next up, we'll be going over some scenarios that really kind of summarize everything that we've been talking about, and then some example responses. So this first scenario here, your son was diagnosed with DMD and given a prognosis of a shortened life expectancy. So what are some non-medical related ways that you can help enhance his quality of life? So here we've just come up with some possible responses, and this includes providing emotional support and counseling for the child. So again, facilitation of open space to talk about thoughts, feelings, or fear. So this kind of ties into approaching end of life care with empathy, as mentioned a little bit ago. And then next we have encouragement of social interaction with friends and family. So this could mean like any forms of like adaptive sports, play dates or social events, and also like virtual meetups just to keep that like connection. Because sometimes patients with DMD could feel isolated. And next up, we have encouragement with hobbies and interests. So again, like anything art, music, gaming, reading, activities like that, that could enhance quality of life. And then lastly, it's important to promote independence and empowerment. So this could include adapted tools such as voice activated devices and computer accessibility features. And then it's also important that the child can make choices about their like daily activities, clothing, or hobbies. So again, facilitating that sense of autonomy. So to just summarize, in addition to kind of the medical component of care, it's also important that we have non-medical related aspects such as like emotional support, kind of this emotional and social like aspect of care is also important as well.
Okay, now we're going to move on to scenario two. So imagine you are a hospice volunteer visiting a DMD patient in a hospital bed. As you enter the room, you notice that the patient is quietly crying with their parent on the bedside. What might be your first action or first thing you say? What kinds of things might you avoid saying? So now we're going to go over possible responses. So some of the main actions to do are first to await cues from their family. If the family beckons you over, or if they allow you to come in, offer a tissue and just really offer active listening. A lot of times patients may not want advice from you. They may just want to be heard and listen and just know that their feelings are valid. Next is to lead with empathy. Make sure to sympathize with the patient without pacifying their reality. Make sure to acknowledge their fears and pain, but try to avoid statements such as, I understand, because it can be extremely difficult and unlikely for us as volunteers to understand what the patient is going through. And by saying that, a lot of times we could mean good intentions, but it could come off as invalidating. Next are some actions to avoid. So make sure to avoid being overly blunt or once again invalidating their feelings. And this can include statements that we would usually say but don't realize that are invalidating, such as, you will be all right, don't worry about it, or don't be upset. Thank you for listening to our presentation. These are just some works cited. Once again, thank you so much for following our presentation, and we hope that you were able to learn some more about end of life care. Thank you.